Good morning. Welcome to Plenary 7, SIMCON 2018. We have a very important topic now, non-invasive ventilation. And I'm going to invite Dr. Pathipan Pillai, who is the chest physician at Luton and Dunstable University Hospital and the clinical director. Over to you, Dr. Pathipan Pillai.
Thank you, Dr. Jayasinka, for your kind introduction, and good morning, everyone. As I know that most of you are the general internal medicine specialists, and also there are many trainees in this audience, and I thought it's better just to focus on my talk on the areas where you need some support. So I will be going through these subheading, just focusing on what are the things as a generalist you need to do when you come across patient with non-invasive ventilation, especially if you have a machine, what you are going to do, and if you are planning to purchase one, what you are going to do. So I will be focusing on that. When you look at non-invasive ventilation, that is the definition of non-invasive ventilation is the ventilation without endotracheal intubation. So most probably that is going to be a mass ventilation, the ventilation without endotracheal intubation. When you have a patient with ventilatory failure, it's better to look at the underlying problem. Normally that there are forces opposing the inspiration exceed respiratory muscle effect, and that leads to ventilatory failure or respiratory failure. There are two forces which normally oppose the inspiration. One is the elastic work of the stretching of the lungs, the factors preventing the stretching of the lung. If you have a very heavy lung, either due to consolidation or due to congestion, it is going to cause problem. It is not going to expand. Or problem in the chest wall is going to cause the same problem as well. If you have a large patient, obese patient, it is going to be a problem. Abdominal distension going to cause a lot of problem in stretching the lungs, so the inspiration is going to be affected. And the second problem is if the airway is obstructed or narrowed. So these are the two causes, the forces which is going to oppose the inspiration and going to cause problem. We call that is a load on the respiratory muscle pump. So if you have a patient with respiratory failure, either the load is increased due to what I said before, or due to the poor pump capacity. The poor pump capacity can be due to either muscle weakness, neuromuscular problem, neurological problem causing the muscle to behave in a suboptimal way. It may be due to malnutrition and wasting of the muscles. It could be due to infection, sepsis, hypoxemia, or hypercapnia causing reduced muscle pump capacity. And the third cause you better to look at is there any problem with the respiratory drive? Whether the patient is on any sedation, benzodiazepine or morphine-like substance, or whether there's any intracranial pathology. So if you have a patient with respiratory failure, it is better to think about those three causes. So you have a patient with respiratory failure, you need to treat that, then you need to have a ventilator. The function of the ventilator is to augment the function of the inspiratory muscles and unload the respiratory muscle. That is the function. Whether it's an invasive ventilation or non-invasive ventilation, that is the function. So if you move on to the non-invasive ventilation, it's a mass ventilation, the ventilation without any endotracheal intubation. The question when we started using 20 or 25 years ago, there were many questions. Will it work? Will it work on the ward? Is there any side effect? Whether we are going to kill the patient? Lot of questions. So it's better to just look at the evidence. So it's better to look at the literature. When you look at the literature is going back in ancient times. The evidence is telling you that it started long time ago, according to Bible. But the randomized controlled trial, the first randomized controlled trial was in 1994-95, and this is the trial by Brochard and others, published in New England Journal of Medicine in 1995. Clearly indicated that the intubation rate is reduced in patients with non-invasive ventilation. Complication rates were fewer, hospital stay is shorter, and the mortality rate also lower. Only thing we need to look at is the trial was conducted in an ITU, intensive care unit environment. So the non-invasive ventilation worked in intensive care unit, and clearly it was demonstrated. So the question at that time is, will it work on the normal ward? This is the landmark trial answered that question. It's a Johnny trial, it's a Yorkshire non-invasive ventilation trial. The early use of non-invasive ventilation for acute exacerbation of chronic obstructive pulmonary disease on general medical wards, a prospective multi-center randomized controlled trial done by Paul Plant and team in Leeds. There were 14 UK hospitals got involved over the 22 months, comparing the NIV with standard therapy. The patient had mild to moderate acidosis, and as I said, the patient were treated with an NIV on the normal ward. There were 236 patients. Half of them had conventional treatment, and half had the medical treatment with NIV. What the trial showed is the intubation rate was lower in NIV compared to control, and the mortality rate was also lower compared to the conventional treatment. So this trial at that time directly addressed the two biggest questions the respiratory and critical care community faced at that time. Is NIV feasible in the real world? And the answer was yes at that time. After this, can NIV be performed successfully outside the ICU? And the answer was strong yes. At the same time, there were other trials looking at the NIV, whether it works or not, whether there's any side effects, whether it improves the outcome. And this is by Giro and the team. Just look at the infection rate. There's a 50-50 patient match case control study. NIV associated with lower risk of nosocomial infection, including pneumonia, UTI, and catheter-related infection compared to intubation and ventilation. Less amount of antibiotics use, shorter length of stay, and lower mortality. So it also showed it did work. Recently, there was a meta-analysis published in 2016, 48 patients looking at non-invasive ventilation in acute respiratory failure. And there is a Cochrane review published in 2017 on non-invasive ventilation and respiratory failure. Both of these studies reveal that there's lower intubation rate with the NIV. There's a lower risk of ICU and ward-associated mortality, and lower length of stay, both in ITU and on the wards, and also the cumulative length of stay in the hospital. So there were huge benefits with NIV. There are also other benefits. Because of the nature of the non-invasive nature of the ventilation and the fact the patients are conscious, the application is easy. It's easy to start the NIV, and whenever you want, you can stop that as well. It's improve the patient comfort. Patient is comfortable. They doesn't need to fight with the machine. It reduces the need for sedation, and the sedation associated side effects were reduced. And the fact the patient is conscious, not intubated, the oral patency is there. Patient can talk, eat, and cough. So it's so beneficial. Since there's no intubation, there is no early or late complication. So no local trauma aspiration, there's no injury to hypopharynx, larynx, or trachea, and also it reduced the intubation-associated infections. So overall, huge amount of benefit, and at the end, it reduced the cost of treating that patient. So what are the indications of non-invasive ventilation? It does work and large amount of benefit. So the indication, the main indication is in COPD with respiratory acidosis. Patient has acidotic pH less than 7.35. PCO2 is more than 49 millimeter mercury. Respiratory rate more than 23. And these patients should be on controlled oxygen and on maximum medical therapy. They are sick, but they are not too sick. If you are going to start patient on two unwell patients, they may not do well. There are other indications as well: obesity, hyperventilation, neuromuscular disorder. We do have more and more patients living longer with this problem and coming with respiratory failure. Patient waiting lung transplantation, and post-extubation. One of the indication, many patients after extubation, when they try to wean, we support them with non-invasive ventilation. What about patients with asthma? There is a lack of high-level evidence. There is no large, well-designed, randomized controlled trial on asthma and non-invasive ventilation. Some support in observational studies and some case series, there are some suggestions. This is a Cochrane review of 5 trials looking at 206 patients. Patient treated with non-invasive ventilation in acute exacerbation of asthma. And that concluded there's not enough data to support the use of NIV. This treatment remains controversial despite its continued use in current clinical practice. And larger prospective randomized controlled trials are needed to determine the role of non-invasive ventilation in patients with asthma. Still, we do come across patients are treated with non-invasive ventilation, asthmatic patient. If you are going to do that, if your anesthetic is going to do that, it's better to do that in an intensive care unit environment with close monitoring, with all the facilities available to intubate and ventilate in case there is NIV failure without any delay. So think about that. There are contraindications. Patient may not tolerate if they are unconscious, or confused, or agitated. If the upper airway, they can't protect the airway, it's difficult. If they do have more than one system failure, it is difficult to do the non-invasive ventilation. So if you have got hypotension or renal failure, things like that going on, it's better to go for intubation and ventilation. Consolidation on chest X-ray could be a contraindication, or you should be careful. And untreated, so you need to treat the pneumothorax with a chest tube before starting on non-invasive ventilation. And severe acidosis or life-threatening hypoxemia may be difficult as well. These are going to be a relative contraindication if you decide at the start of the non-invasive ventilation that you are not going to escalate the patient for intubation and ventilation in the event of NIV failure. The ceiling of treatment, if you think is going to be a non-invasive ventilation, then you may consider treating all those patients with contraindication. But if you think that you are going to escalate, this patient is young, good quality of life, then it's better consider not to go through NIV. It's better to go for intubation and ventilation. For the next few slides, I just want to say a few words about the ventilators. If you look at the ventilator, non-invasive ventilator, there are 2 types. One is a bi-level ventilator. There's a different pressure or volume in inspiration and expiration bi-level. And the second one, you may or may not call that as a ventilator, is a CPAP machine. continuous positive airway pressure is a continuous pressure. So when you look at the bi-level ventilator, and there are volume preset that the ventilator will give a fixed amount of volume to ventilate the patient. And the second one is a pressure preset. It will give a fixed amount of pressure to ventilate that patient. Nowadays, we don't use the volume preset ventilator. It is almost obsolete, or we don't normally use that. So we shall concentrate on the pressure preset ventilator. It's a BiPAP, bi-level positive airway pressure machine, combination of IPAP and EPAP. IPAP is an inspiratory positive airway pressure, and the EPAP is the expiratory positive airway pressure. Always the inspiratory pressure is higher than expiratory pressure. So when you look at this curve, that in a CPAP, if you are starting a patient on CPAP, the pressure is going to be constant both during inspiration and expiration. So around 5 centimeter water, or 6 or 3 or 4, so constant, so it doesn't change. That is a continuous positive airway pressure. When you give a bi-level ventilator, during expiration, the pressure is lower, around 5, almost similar to the CPAP pressure, and on expiration is around 15 or 20 or 10. So there is fluctuation because inspiration ventilate, expiration oxygenate. I will come to that. So if you look at the respiratory effect of BiPAP, if you look at the inspiratory positive airway pressure, it does augment the alveolar ventilation. It increases the tidal volume by giving the pressure. It increases the tidal volume, which helps to reverse the acidosis and hypercapnia. It also reduces the work of breathing and respiratory effort, which in turn reduces the inspiratory muscle work, which in turn reduces the fatigability and the oxygen demand. Both of them will reduce the spontaneous respiratory rate of the patient. So IPAP normally ventilates the patient. When you look at the EPAP, it provides a peak expiratory pressure. It also, because it's almost like a CPAP, so it increases the functional residual capacity. And also by giving that EPAP, it recruits the alveoli. The alveoli opens up and kept opened. So it opened up the alveoli, it recruits the alveoli, so alveolar capillary basement membrane surface area is going to be increased, so it helps the oxygenation. So EPAP oxygenate, IPAP ventilate. When you look at the CPAP, CPAP is almost like a continuous EPAP. So it is the same pressure during expiration and inspiration, but the low pressure. So the mechanism is same, so it is going to oxygenate. So help in the type 1 respiratory failure. It also slightly helps the ventilation as well, but the main thing is it will oxygenate. So it is useful in hypoxemic failure or type 1 failure or lung failure. So cases, indication like cardiogenic pulmonary edema, pneumonia, acute lung injury, contusion, lung contusion, all those things might be treated with CPAP. I just want to touch up 3 slides on the mode of ventilation. You may have a machine waiting there in your emergency department or planning to buy one. So when you look at the BiPAP, the pressure support mode, the mode, there are 3 things I want to say that. One is a spontaneous mode or assist mode. That is, the machine will support the ventilation when the patient breathes. If the patient does not breathe, the machine does not do anything. So machine will augment the breath of the patient every time the patient breathes. So it's a spontaneous mode. Pressure support ventilation is a spontaneous mode. If the patient doesn't breathe or breathes in a 10 or 9 or 8 breaths per minute, it will also support only the 8 breaths per minute. The second type is a spontaneous time mode. That is, it has got the spontaneous mode that it is going to support or augment the breathing of the patient every time the patient breathes, but it has also got a backup rate set by the operator. So if the breathing rate goes down below 8 or 10, if the backup rate is 10 or 8, then the machine start to pump air. It start to overtake the patient breathing and control the breathing. So it's a spontaneous time mode, it's a ST mode, and it is safer. And this is the machine we normally use all over the country, here and also in UK. It's a support from the ventilator is commonly used. And the last one is there's nothing there. The patient does not do anything. It's the time. It's a full control by the machine. It's a preset inspiratory pressure. It's a full support. All the breaths are machine triggered, and there's no participation by the patient. There can be difficulty in synchronizing sometimes. The patient might be fighting with the machine in that. So there's a 3 mode. One is a spontaneous time, and now is a time that is a full control by the machine. So remember that. So if you have a patient with a COPD waiting in the emergency department, you may have the machine, the ST machine. So normally what we do is you start the IPAP pressure around 10 centimeter water, EPAP 4 centimeter water. As I said, IPAP will ventilate, EPAP will oxygenate, and the inspiratory time, depending on the respiratory rate of the patient, and normally is around 1 second or so. And the backup rate, probably you set around 10 breaths per minute. And the oxygen, how much oxygen you are going to give, depending on the target saturation. And it's better to go for 85 to 90% saturation. That is enough. These patients have been living with hypoxemia for a long time. Don't try to correct that too much. So start with a 10 IPAP and a 4 EPAP, and increase the pressure gradually by 2 to 3 centimeter every 5 minutes to the maximum of 20 centimeter. And the reassess after 1 hour. The decrease in the respiratory rate and improvement in the pH is a good predictor the patient is going to do well. The main thing is the respiratory rate. So that will tell you this patient is going to do well. So when you are monitoring the patient by looking at the patient, whether the patient is becoming more and more comfortable, whether the respiratory rate is coming down, the pulse rate is coming down, and the chest wall movements are better, and the accessory muscles are not working now, it doesn't need, and the patient is coordinating with the machine, all are telling that this patient is getting better. You need to continuously monitor this patient with the pulse oximetry. If there's no significant improvement after 4 to 6 hours, it is very unlikely this patient is going to get better, provided you have been changing the pressure and doing everything correctly. Then you need to decide. If you have already decided that I'm going to intubate and ventilate in NIV failure at the start of the NIV treatment, then you are going to call your anesthetic colleagues and ask him to come and intubate and ventilate. If this is a ceiling of treatment, then you may continue and go for palliative treatment. What about weaning? As these patients are conscious, when they are better, they auto-wean, they take it out. They know they are very well. They themselves wean it from the machine. Otherwise, look at the respiratory rate, heart rate, pulse, blood pressure, pH, and see whether you are going to do that. And especially, if you are going to stop the machine, first stop it during the daytime and continue during the nighttime, in order to just prevent that REM sleep-associated hyperventilation and nocturnal problem. And then after 1 or 2 days, then you may completely stop the machine. The main problem we do come across in non-invasive ventilation is the interface. Patient can't tolerate. There can be side effects. So you need to choose the best one. It should be comfortable. It should not leak, and should not cause any pressure ulcers. The main complication is a pressure ulcer. So you need to be careful. So ladies and gentlemen, that the success of the non-invasive ventilation depend on those 3 factors. The main thing is the clinician's skill. This is a conscious patient, lot of interaction between clinician, patient, and the ventilator. You need to spend large amount of time sitting with the patient and talking to the patient and holding the mask for the patient to get used to that. So the skill of the clinician is much more important than the capacity of the ventilator. Remember that. The success is going to depend on you and your supporting workers, including the nurses. You need patience and time, and it is an art, the non-invasive ventilator. So just to conclude, non-invasive ventilation is the most important advance in respiratory medicine in the last 3 decades. And the trial of NIV should be considered early in the course of acute respiratory failure as a means of avoiding intubation and reducing hospital stay and mortality. Patient selection is important. You need to choose the patient well, and they are sick, but they should not be too sick. And physician with an interest and time in their timetable to look after these patients should be available. There should be a good and supporting nurses in a designated ward to look after this group of patients. And you should also have a good working relationship with an anesthetist. They should be informed that you are starting a patient on an NIV and they may need intubation, so it's better to inform them. And especially in Sri Lanka, I feel that all the acute hospitals, whether it's small or large, all should have a small dedicated team, maybe a few nurses, couple of nurses and a consultant interested in NIV should be there to provide this important service. Thank you.
I want to thank Dr. Prathipan for this interesting lecture. I think it is very well balanced academic aspects and basics of the NIV was covered. Thank you, Dr. Prathipan. With the setup of new emergency treatment units all over the country, mainly managed by our internal medicine physicians, I am sure you will have more questions to ask him. I think he's happy to answer.
Thank you very much for the comprehensive talk. Now, we know that there are few inherent problems with NIV as well, but now the high flow nasal oxygen had been in use in pediatric practice, which of course is coming to adult practice as well. So what is your experience and advice for the physicians who actually now we have been using NIV for the last 4 or 5 years? So what is your advice on high flow nasal oxygen for hypoxemic respiratory failure?
High flow nasal oxygen. I think, I really wanted to touch that, but I didn't have time to do that. The question always is, the anesthetist may or may not believe in that is, am I going to remove the hypoxic drive in patient whom you are going to consider high flow oxygen or high concentration oxygen? That's the thing you are talking about, is that right? I see. If you are going to talk about type 1 respiratory hypoxemic, yes, you just go for the I think nasal prong and the CPAP and the nasal high flow oxygen, you can go for that. And it does work. So try that first. And if that works, continue that. It's almost the mechanism is same. You go for that. If that doesn't work, then I think it's going to either you are going to go for intubation or just seal the treatment. So I will. But the question is whether that hypoxemic patient has he got type 2 respiratory failure as well. That is a different patient. This is a pure type 1 respiratory failure. That the treatment is oxygen with other measures. Yeah. Derek, you wanted to say something? Yeah.
questions. So we'll conclude the plenary 7 for the symposium of Society for Internal Medicine Society. May I call upon Prof. Tilak Jailat to hand over the certificate of appreciation. He's one of our founder leaders for initiation of Internal Medicine Society. Thank you, sir.
Ladies and gentlemen, the next session is a symposium 5. The topic is radiology for the internists. We have two giants and giantess in radiology. May I have Professor Bhadra Hevavitarna, Dr. Vikrama Salgadu and Dr. Sanjeev Munasingh here. Dr. Bhadra Hevavitarna will be speaking on choosing the appropriate radiological investigation.
Good morning. First of all, let me thank Professor Senaka Rajapaksha and the organizing committee for giving me this topic to speak to you all, choosing best radiological investigation. I hope I will do some justice to this topic without confusing you too much. So this is my overview. I'll be going through these topics during these 20 minutes. And as you all know, the current practice of medicine, radiology has become an integral part, not only in diagnosing aspect but also on further management, like in interventions in interventional radiology. And as clinicians, you know, clinical scenarios mostly end up in differential diagnosis and resulting in further evaluation with either laboratory investigations or radiological investigations to come to a more definitive diagnosis. And we are sort of confronted with plethora of radiological investigations, and so we need to come to a consensus on choosing appropriate radiological investigation or investigations in a given clinical scenario. So I have put forward this slide. I think this poor internist is having a clinical problem or a lot of problems, but I don't think even, radiologists can easily go there. And we have two sets of radiological investigations. On one hand, we have ionizing radiation, and on the other side, we have non-ionizing, which we love it, but unfortunately only two of them. And ionizing radiation investigations are still on the high side. So it spans from plain radiography to fusion imaging, as you can see. So you're all familiar with these sort of two sets of imaging methods. So we'll see. And if I were to sort of define what is the best radiological investigation, I would sort of consider an investigation which would answer a given clinical problem with a minimum financial burden, either to the patient or to the institution, and which outweighs the benefits over risks, and it contributes to optimal patient management. But do we have such thing? I think one-stop shop imaging is still yet to be born. I think engineers are still working because we always get our stuff from biomedical engineers. Then what factors would govern selection of a best radiological investigation? as I have highlighted, clinical scenario is the most important thing, and then comes the age of the patient, because younger the age, we will move away from the ionizing radiation investigations and the organ involved and the region of interest, and of course the pathological concern and imaging tools available at the institution, or I think we are a small country, we can consider as a whole even in the country, and ionizing radiation hazard, and of course the expertise, and last but not least the cost. So if I were to take you through some clinical scenarios of hypertension and 3 different patients. So 8-year-old girl for hypertension for 8 months, asymptomatic on 2 antihypertensives, and young lad, 18-year-old male, hypertension for 1 year, asymptomatic on 2 antihypertensives, and 60-year-old female, not so old according to current WHO recommendation, and high blood pressure for 15 years with intermittent orthopnea over last 6 months, and she's on 3 antihypertensives. So we got, same disease, different clinical scenarios. So we know the differential diagnosis is like this. So if we are to select the imaging, so all 3 will undergo preliminary ultrasound and Doppler, which will give you very little, or they might direct you somewhere. If you see a sort of adrenal mass, you know where to go. Then 2 and 3 patients will undergo chest X-ray, because there is a chance of having coarctation in young patient, and on the other hand, the third one, the elderly one, may be having, not elderly, I will emphasize again, 60-year-old lady will undergo chest X-ray because she is getting recurrent orthopnea. Then the number 2, the young patient, 18-year-old, will be best assessed by abdominal CT or CT angiography or MR angiography. If coarctation is clinically or on chest X-ray, it is eliminated, which we can do. You all know better than me how clinically you can exclude, and chest X-rays, if you are vigilant enough, you get the answer by the time they present with coarctation. So all 3 of will be, if I were the sort of radiologist looking at this patient, and to give, if somebody asks me, a clinician, what is the best way that you can do this, assist this patient, after eliminating all the other things, if it is the case, the renal artery stenosis, I would say I would do a DSA, catheter angiography, because at the same sitting I can go and do angioplasty. So it will reduce the burden of contrast-induced nephropathy, radiation. So that is why I have put it in another clause, confounding is expertise. If lacking, if you do not have the expertise in this institution or nearby institution, go for CT or MRA prior to angioplasty, not at the same sitting. Right, so when we think of the organs and the pathology, so you all know pancreas is a deep-seated organ, and the clinical scenarios are very non-specific. So ideally, either you do CT or MR, depending on the availability, but pancreatitis, trauma, and ICU setting, definitely we will go for CT, because of MRI takes time and not so easy to do. And if you are thinking of neoplasms, you will definitely go for MRI more than CT, especially in case of insulinoma. You will be happy to, it is better to go for MRIs rather than wasting your time on CT, because you may get a chance of not getting your insulinoma diagnosed. You can see, as you can see here, tiny insulinoma. And of course, these are 2 CTs. CT is also good enough if you do it properly, and it is a tailor-made investigation. You have to do correct pancreatic phase imaging, otherwise you are going to lose it. And you can see sometimes it is very tiny and just a bulge in the pancreas, still it could be insulinoma. So you got this, that is why I put more than and equal. So it is the availability in the institution as well as the expertise and the dedication for the clinical scenario. And then the expertise, as I have put it here, you need technical and interpretation. I'm talking about a radiologist, so you need to properly select the examination, and you need a good conduct of examination and interpretation. You can't interpret if you have not done the proper protocol examination. So you need to conduct the examination, and the expertise, selection of expertise, or I think this MDT, that is the way out to select our sort of, in our setup, in a, limited resource setting. So if I may take you through the sort of radiation doses, I think you all are aware of these things as put across by the International Commission on Radiation Protection. You can see, we are confronted with natural background radiation. So in addition, man-made radiation, so we have to keep it to minimum. So chest X-ray is a fairly sort of, safe procedure. You get only 0.0 millisieverts, but you can see multiphase abdomen, it's 30 times more than that. And others are also not that bad. But coronary angiography 5 to 15, and if you were to compare 20 months to 5 years of background radiation, abdominal CT, it is 10 years of background radiation if you do one CT, multiphase CT. But it is said if it is less than 10 millisieverts radiation dose, it is not a sort of a serious sort of radiation problem, so it is considered relatively safer. And mind you, natural background radiation 3 millisieverts, and every year we are accumulating, and there's a thing called stochastic effect in radiation, which you will accumulate and lead to radiation-induced malignancies. So then I will take you through the current evidence. Unfortunately, Sri Lankan guidelines are not available. We did it in 2008. We did on 10 common clinical scenarios, but actually it was implemented during that time, but it did not sustain. So I'm very sad to say that. But we have, we are inundated with international guidelines. Every developed country has their own guideline. So Royal College of Radiologists, they have their guidelines based on clinical scenarios, and latest update in 2017, and you can see even the American guidelines 2017. And if you go to this website, you will see it's 190 clinical scenarios. So each and every clinical scenario, they have given which way to go in your clinical problem. Similarly, Royal College of Radiology, but they are a little bit, it's difficult to get at there because it is only open for their members. And you have Canadian, European, New Zealand, so you name it, they will have their own guidelines. Then I will take you through a few clinical scenarios because I can't be going through 190 clinical scenarios. Then acute pyelonephritis, that is a common thing I thought internist will be embarked on. So there is, the current guideline is no place or very little place for KUB. When we were medical officers, we used to do KUB for all the pyelonephritis patients, unless presented with renal colic to see a presence of a calculus. And ultrasound is actually merely not indicated unless, again, unless it is complicated. Because only 25% of uncomplicated acute pyelonephritis will have positive features on ultrasound. So it does not exclude, so why should we bother? But in our day-to-day practice, we get a lot of patients with acute pyelonephritis. But it is definitely indicated if it is complicated or management is guided by these ultrasound findings. So what do we look for in hydronephrosis, abscess formation, perinephric collections, emphysematous pyelonephritis, or infarctions? If you put power Doppler, we may see even hyperperfused areas on ultrasound. And CET, of course, in complicated cases, so you may see these things as in ultrasound. But CT is better in calculi, especially in mid-ureteric calculi and in gas collections. Of course, MRI, what is the place of MRI? MRI is only limited for UTI in pregnancy because no added findings. It's similar to CT. So these are a few examples. You can see when you compare normal kidney, this side is enlarged, swollen, low echogenic kidney with altered echo pattern. But mind you, this is very, very non-specific. And this is a case of emphysematous pyelonephritis. AI is producing a lot of shadows behind. And CT, of course, it's a problem-solving tool. So you can see this nephrogram, you can see low-density areas. They are not contrast-enhanced. So that is the thing that we see, lobonephronia in acute pyelonephritis. Or else, if you can see this striated nephrogram, that's nice. So this is a complication, coming to a renal abscess. Or it may rupture and go to the perinephric space, or you may see emphysematous spinal nephritis with gas shadows. And another scenario, that's renal artery stenosis, which I have dealt with, but just to recap, MRA is the best non-invasive diagnostic tool if available at no cost of radiation, but caution is EGFR. If it is less than 30 ml, there's a chance of getting nephrogenic skin fibrosis. And CT angiography has got better spatial resolution than MRA, but it has got radiation, and it detects calcified plaques, and it is used above. The MRA is not available or contraindicated like in pacemakers, claustrophobia and things. But still you have to remember GFR, if it is less than 60 ml, because you have the problem of contrast-induced nephropathy, but you can sort of prepare your patient for dialysis afterwards. Doppler ultrasound, yes, it is a screening test, as I said before, and captopril if you want to find out the functionally significant renal stenosis before you embark on angioplasty. And DSA and catheter angiography only when endovascular or surgical revascularization is considered. So you need to select your patient according to the available imaging methods and the expertise in the institution. So these are few images, the MRA and CTA, just sort of nice pictures. This is showing fibromuscular hyperplasia, and this is showing athermatous renal artery stenosis. And these two are volume rendered 3D images of bilateral renal artery stenosis, and this one right-sided. So you get nice imaging pictures now with the current available imaging modalities. So acute stroke, I think this may be addressed in somewhere else also in this conference. But we always do NCCT brain, and it is done urgently within 4 to 5 hours. I think now all the hospitals are geared for this, where you have stroke units, so which enable thrombolysis at least within 24 hours. We try to do it, and differentiate ischemic from hemorrhagic stroke, and to exclude if there are any other causes. Sorry. Then MRI brain, also there is a place, though it is not freely available, if the underlying pathology or diagnosis of stroke is uncertain, or the stroke imaging has delayed by about more than 1 week because it's insensitive to exclude hemorrhage by this time, and in young strokes, and also posterior posterior circulation infarcts. And CTA or MRA, it is actually definitely it's indicated in mechanical if you are considering mechanical thrombectomy. And similarly, CT or MR perfusion or MR diffusion weighted, that is also indicated when you are contemplating mechanical thrombectomy. Is there a place for CTV or MRV? Yes, if venous thrombosis is suspected to be the cause of stroke. And carotid Doppler, of course, yes, it is. We have to do it within 2 weeks of TIA or stroke, which is right now we are having a problem in our hospital. There are so many strokes. Stroke unit is there. We are supposed to do Doppler ultrasound within 2 weeks. Only one ultrasound machine is functioning properly. I'm sorry to take you away from the discussion. Then choice depends on local expertise and availability of imaging modalities. So these are some images. So if you are lucky, if you are in the hospital while having the stroke, within 30 minutes you can do a CT. So nothing is seen on the CT, but if you do a CT angiogram, you can see this left MCA is not filling there. And if you do DWI, yes, of course, you can see within 60 minutes the changes in the infarcted area. So this is within 4 hours. You can see how nicely conventional MR with T2 weighted is not showing much, but DWI is nicely showing you the infarcted area. And CET also, it can go extra mile if you have perfusion images. So this area, the frontal lobe, you can see there's an infarct. But CET perfusion will take you through another lesion, which is shown on MR as an infarcted area. So this is another sort of area. If you have MRI and if you have a sort of a problem, you can go for susceptibility imaging, and it will show you a blooming artifact, which is the sort of thrombus within the artery, which is giving that. All the others will be positive in that case. Then what are the current concepts on imaging modalities? If you were to take plain radiography, mostly now it has become a preliminary examination, but I don't want to sort of say that it is not an obsolete investigation in settings. But you have to be vigilant the application. And ultrasound CT has taken over the role of plain radiography very much in most of the clinical scenarios. But still, chest X-ray is a sole imaging tool in uncomplicated community-acquired pneumonia, as you may know, and chest X-ray is a preliminary imaging tool for chronic cough and shortness of breath. In a patient comes with heart failure, you don't go and do a CT, though it is the best way to look at your alveolar airspace shadowing. And chest X-ray is a good follow-up tool for most of the diseases, including TB. And abdominal X-ray, it has become a preliminary imaging tool for acute abdomen in adults, but in children, we don't do now much X-rays because ultrasound has become the preliminary imaging method in acute abdomen in children. And skull X-ray, of course, sad to say, it has become an obsolete imaging tool, but only place is still in institutions where CT is not available. Your forensic experts will require these things, but definitely not for headache and other CNS symptoms. So ultrasound, when you talk about ultrasound as imaging method, it's a workhorse of most radiology departments in Sri Lanka. And it is diagnostic in superficial organs like thyroid, testicle, scrotum, and gallbladder, and of course breast, less than 35 years, symptomatic breast. It's not a screening tool. And venous duplex, DVT and chronic venous insufficiency, you don't have to go for any other thing unless you are trying to put a IVC filter for that patient. And gynecology, some of the things so as a diagnostic tool. So these are some of the pictures of diagnostics tool. So this is thyroiditis. So you see micronodulation in thyroid, and which has led to chronic fibrotic stage with fibrotic stranding. And gallstones, I don't have to elaborate on that. And this is an interesting case, ovarian dermoid, giving this dermoid plug or sugar ball appearance. There's no differential diagnosis for this. So this is an ovarian dermoid. So that is diagnostic on ultrasound. Then when it comes to CT, it is considered 9% of all imaging, but it contributes enormous, about 50%, half of the all medical radiation. So you need to be vigilant about this when you are requesting a CT investigation. Am I doing the correct thing? But it is a problem-solving diagnostic tool on the other hand. And because it has got the advantages like cross-sectional imaging, multiplane reconstruction imaging facility, and density characterization, you can say with its blood or thick fluid, and its universal availability, but I don't know in Sri Lankan scenario. So it's frontline in the following, like acute abdomen, perforation and bowel obstruction, which the plain X-ray was used to be, and of course in pancreatic pathology. And in the chest, high resolution CT for ILD, and CT angiography for CT pulmonary thromboembolism, aortic dissection, and CT chest for infective, inflammatory and neoplastic diseases. And these are some of the CT applications. Okay, I'll be finishing very soon, yeah. So pneumoperitoneum, if you are not vigilant enough to detect a very tiny sort of pieces of pneumoperitoneum, CT is the way out. And active bleeding, as you can see here, there's a bleeding into a colonic diverticulum. But there are pitfalls in ordering CT abdomen. Acute pancreatitis, if you order it's less than 72 hours, you have a chance of missing it. If you have MRI, yes, MRI is more sensitive within the 72 hours. But unless the clinical scenario is warranting, you have to think twice. Then GI bleeding, if the patient is not actively bleeding, you have to reconsider doing the CT, and CT immediately after abdominal CT. So this is a nice, it's not nice actually, saddle thrombus involving two major bronchi, and UIP pattern with honeycombing, and NSIP pattern with ground glass appearance. And MRI is considered the best, one of the best selection for these conditions. Of course, pituitary tumor, posterior fossa tumors, and spinal pathology, nerve pathology like brachial plexus or any other nerve, and mostly a problem-solving tool for breast, thymus, and mediastinum. As you can see here, this one is showing a tiny microadenoma in this MRI, and this is just to recap your normal anatomy. And this one is an interesting case. This one has got metastasis in the pituitary stalk and in the pituitary gland, and presented with diabetes insipidus. And this is intracanalicular tiny acoustic neuroma, as you can see here. No other imaging method will give you this. So if a patient has tinnitus, if this, no point going for CT, straight away you can go for MRI. So multiple imaging studies, I think we had to keep away. So these are certain areas which we get request CT brain with and sinuses at the same time for headache. MRI and MRA for headache, MRI cervical spine and shoulder for shoulder girdle pain, the lumbar spine for and hip, so on and so forth. So we have to keep away from this practice because you have to be more focused and order one investigation. Definitely the results of the first one will take you to the second investigation, and repeat examination also the same. So should not be done merely because records are not available or cannot be traced, which is a common practice in hospitals. So, Chairperson, I am concluding that in summary, selection of best radiological investigation is multifactorial, mainly the clinical scenario and the radiation hazard you have to take into consideration, and cost and availability are main constraints, and available guidelines such as American Royal College we could adopt but cannot be blindly applied locally. So formulation of local guidelines on imaging algorithms of common clinical problems should be revisited by our college in collaboration with other colleges. And infrastructure should be improved, like more importantly, improved patient to radiologist ratio. So thank you very much for your patient listening. I think we should get to the Sri Lanka College of Radiologists and Society of Internal Medicine should get together and make these building blocks. Thank you very much.
Thank you, Professor Hewa Vitarna. The next speaker is Dr. Vikrama Salgadu on investigation of back pain. Dr. Salgadu.
So, good morning. Topic assigned to me is radiological investigations of backache. So why is backache important? Low back pain is a very common symptom, which can affect about 80% of the population at least once in lifetime. Each year, 15 to 20% of the population will have back pain. And it is the second most common reason for symptom-related physician visits. Low back pain is the most common site of chronic pain. It is the most common cause of work-related disability. So why do we need to take it seriously? Acute low back pain is often recurrent. It predisposes to chronic pain and disability. It may be a warning of potential future trouble or sinister underlying pathology. It can have a significant impact on quality of life. It may lead to lost days of productivity. However, uncomplicated, non-specific acute low back pain is usually a benign and a self-limiting condition that does not warrant any imaging studies. There is a high rate of spontaneous remission, most without a specific diagnosis. And only 7% will become chronic. On the other hand, degenerative changes are frequently detected in the aging spine. MRI shows disc pathology in majority of adults and many asymptomatic people. So imaging is likely to result in an abnormal report. All positive findings may not be attributed to the acute presentation. So we need to determine whether it is actually abnormal or just is it just normal aging. Therefore, it is imperative that the imaging findings be correlated with the clinical findings. The differential diagnosis of acute low back pain, it could be intrinsic to the spine, it could be systemic, or it could be referred. I'll be mostly concentrating in this group. Common causes of low back pain, it's mostly mechanical. So the challenge for the clinician is to distinguish that small segment within this large patient population whom should be evaluated further to look for emergency and catastrophic causes. Clinicians should be aware of the indicators of a more complicated status, often termed red flags. The yellow flags, which are patient characteristics that can indicate long-term problems requiring greater attention. So the red flags indicate possible serious pathology, and it indicates the need for further investigations. There are red flags indicating possible fracture, possible tumor or infection, and possible significant neurological deficit. I'm not going to go through the whole list, and if this list is too extensive, there's an easier mnemonic, that is tuna fish. So yellow flags are patient characteristics that can indicate long-term problems requiring greater attention by the physician, particularly in terms of returning to work. Again, I'm not going to go through the whole list to save some time. So once we have decided to evaluate backache radiologically, there are various modalities available to us. Most frequently, we use X-ray, CT, and MRI. Less frequently, we use nuclear medical imaging, that is isotope bone scanning, PET scanning, and maybe DEXA scan. And myelography and discography is only occasionally used. So when it comes to plain radiography, the advantages are it's a widely and readily available investigation. It is fast, and it's a low-cost investigation, and it gives good bony details. So therefore, it is very useful in trauma. So the disadvantages are exposure to radiation. It gives only a 2D image and gives very poor soft tissue details. So therefore, it has limited use in infection or inflammation. Vertebral alignment can be easily assessed on a plain radiograph. For example, this X-ray shows anterolisthesis of L4 over L5 vertebra. Advantages of CT are it is a relatively available investigation. It gives excellent bony details. The images are available in multiple planes with 3D reconstructions. Therefore, it is useful in trauma and when MRI is contraindicated or not available. For example, this CT elegantly shows a burst fracture of L1 vertebral body. So the disadvantages of CT are exposure to radiation, high cost, relatively poor soft tissue details compared to MRI. Therefore, its use is limited in disc pathology or nerve root compression. So the advantages of MRI are there's no exposure to radiation. It gives excellent soft tissue details, and multiplanar images can be acquired. So therefore, it's very useful in disc disease, infection, inflammation, and metastatic disease. The disadvantages are it's not a widely or readily available study. It's time consuming, high cost, and false positives. That is, it's too sensitive. And as I mentioned earlier, most adults will have some changes. So it is not used as a primary investigation in trauma. A few examples of MRIs being used to good effect. This MRI shows acute osteomyelitis with discitis. And this MRI shows vertebral spinal TB. And this MRI shows multiple vertebral mets. The nuclear imaging, that is isotope bone scan and PET scan, the main advantage is that the whole body can be evaluated at once. Therefore, it is very useful in evaluating metastasis or occult infection. There are many disadvantages. For example, exposure to radiation, limited availability and high cost. It gives poor anatomical details. There are false positives, for example, in elderly due to the presence of OA. And there are false negatives, for example, with diffuse bone mets and multiple myeloma. So its use in intervertebral disc or trauma is very limited, and certainly not for primary imaging. So this is a bone scan showing multiple vertebral mets, and this is a PET scan showing multiple mets. So one other factor that we should consider when choosing a radiological investigation is the radiation dose. To determine the radiation burden of a certain study, we tend to compare it with the dose of a chest X-ray. For example, lumbar X-ray will be equivalent to 75 chest X-rays. And a lumbar CT will be up to 500 chest X-rays, so it's quite a high dose. And a bone scan will be around 300 chest X-rays. And a PET scan will be much higher. So how do we decide on the most suitable diagnostic test? It may be a little tricky as there are various factors to consider. Fortunately, there are accepted guidelines, as Professor Bhadra mentioned. For example, diagnostic imaging pathways developed by the Government of Western Australia, available in this website, and ACR is American College of Radiology appropriateness criteria, available in this website. A word or two about this diagnostic imaging pathways. It's a very useful site where it gives imaging pathways for many clinical scenarios, and it's available for free. So this you may not, This is from Diagnostic Imaging Pathways. The clinical scenario is acute low back pain. So if there's back pain only, that is without neurological symptoms, you consider red flags. So if there are red flags, you go for a plain radiograph. If there are no red flags, conservative treatment, and if the patient has not improved, you have to go for a plain radiograph. So with the plain radiograph, the cause for pain is found, then treat or further investigate as necessary. And you may proceed for an MRI. If the cause for pain is still uncertain, you go for an MRI. And if the MRI is contraindicated or not available, you can go for a CT study. If we are suspecting bony mets or multifocal infection, we can go for a bone scan. Similarly, if there are neurological symptoms or signs, we can go through this path. So this is the ACR appropriateness criteria for clinical condition low back pain. So there is an appropriateness criteria scale from 1 to 9, 1 being least appropriate and 9 being the most appropriate. For example, MRI will have a low score of 2 for uncomplicated low back pain without red flags. On the other hand, MRI will have a high score of 9 for Koda-Equina syndrome. And as expected, CT and X-rays will have a high score for trauma. And if we are suspecting cancer, infection, or immunosuppression, a bone scan will have a higher score. Disc nomenclature. Yes, you the clinicians and we the radiologists, it is very important that we communicate in the same language, because disk nomenclature has changed over the years. All concerned need use of standard terms and current definitions for normal and pathologic conditions of lumbar discs. There are various not too dissimilar terms like disc bulge, disc herniation, disc protrusion, disc extrusion, disc migration, and disc sequestration. All of these will have a different meaning, and a specific meaning. Lumbar disc nomenclature version 2.0 published in the Spine Journal of November 1st, 2014 gives a good account of disc nomenclature, and I have used this as a guide for the next few slides. This is a normal disc in a CT study and in a MRI study. So a disc bulge is annular tissue projecting beyond the margins of the adjacent vertebral bodies over more than 90 degrees, that is more than 25% of the disc circumference. A circumferential disc bulge will involve the entire disc circumference, and an asymmetric disc bulge does not involve the entire circumference but more than 90 degrees. This is an MRI study showing a disc bulge in the right side and a normal disc in the left side for comparison. A disc protrusion involves less than 25% of the disc circumference, that is less than 90 degrees, And it will have a broader base and a narrower dome. So that's an example of a disc protrusion. Disc extrusion, on the other hand, will have a wider dome and a narrower base. That's an example of a disc extrusion. Disc migration is displacement of disc material away from the parent disc. On disc sequestration, the migrated disc will lose its direct continuation with the parent disc. So it's kind of a free disc fragment, as seen on this MRI study. An annular fissure is separation between annular fibers. The term annular tear is best avoided. So intervertebral disc herniation or Schmoll's node is disc material displaced beyond the disc space through the vertebral end plate into the vertebral body. So this CT and this MRI shows intervertebral disc herniation. So this is a summary of disc diseases that I have already discussed. So disc localization in horizontal or axial plane. For example, a disc protrusion may be into the central zone, or maybe into the subarticular or paracentral zone. It may be into the foraminal zone. It may be into the extraforaminal or far lateral zone, or into the anterior zone. So this is the same thing in a more colorful and attractive diagram. The localization in sagittal and coronal planes. For example, a sequestrated disc may be at the disc level, at the suprapedicular level, a pedicular level, or in the infrapedicular level. This is the same thing in a coronal plane. The grading severity of canal compromise or canal stenosis. If the canal compromise is less than 1/3 of the canal at that section is mild. If it is between 1 and 2/3, it's moderate. And if it is greater than 2/3, it's severe. The same grading can be applied for foraminal involvement. So what are modic changes? The modic classification describes degenerative and inflammatory changes involving the vertebral end plates and the adjacent vertebral bodies as seen on MRI. So modic type 1 is when The vertebral end plate and the adjacent vertebral body is low signal on T1 weighted study and high signal on T2 weighted study. So it indicates inflammation or edema. On modic type 2 is when when it is high signal on T1 weighted and high signal on T2 weighted study. And it represents fatty replacement of bone marrow. Modic type 3, it is low signal on T1 weighted and T2 weighted studies. It indicates reactive sclerosis. So these are actual MR images. This is T1, this is T2, again T1, T2, and this is T1, and this is T2. This is modic type 1, this is modic type 2, and this is modic type 3. So in conclusion, to summarize, backache is a very common symptom. It is important to identify the red flags and the yellow flags of backache. Incidental degenerative findings are very common in the lower spine, and it is important to determine whether they are actually abnormal or is it just normal aging. Correlation of the imaging findings and clinical findings is therefore imperative. Various imaging modalities can be used to evaluate backache. Accepted guidelines are available to assist clinicians to select the most suitable diagnostic test. All concerned need usage of standard terms for the normal and pathological conditions of lumbar discs that can be used accurately and consistently and thus best serve patients with backache. Thank you.
Thank you, Dr. Salgado. The next speaker is Dr. Sanjeev Munsinga, who will be speaking on neuroradiological investigations. Dr. Munsinga.
Yeah, when you have too much of technical advancement, you're asking for troubles as well. First of all, let me thank Professor Senaka Rajapaksa and the organizing committee giving me this opportunity to talk to you on recent advance in radiology. During past 20 years or so, there had been outstanding revolution in radiology, which has greatly influenced not only the practice of radiology, but that of medicine as well. The major key to these successes, the technical advancement, both in software and hardware, and the ability to produce computers powerful enough to reconstruct accurate body images, yet small enough to fit into radiology department comfortably. These advancements you can see in both diagnostic and interventional radiology. But today I'm concentrating only on diagnostic radiology. When I started radiology, that was the latter part of the 80s, we had only structural imaging. But today, with this advancement, we have several functional imaging modalities you will understand when it's going through. These advancements you can see in each area of these fields, each modalities of radiology in different degrees. In plain X-ray or plain radiography, the main advancement is digital radiography with post-processing facility and archiving ability. in this chest X-ray of an adult patient are in different contrast levels, different window levels. You can see the soft tissues, you can see the bones, you can see the lung, you can see the lung vessels, whatever the way you want, and you can magnify, you can zoom, and you can measure accurately with these post-processing units. So you don't have to repeat the X-rays. In ultrasonography, with high-frequency transducers, 2-day array transducers, 3D transducers, and tissue harmonic abilities, powerful Doppler tools, elastography, and micropure softwares, you can produce good quality images with better contrast and resolution, which will give better tissue characterization. And we can do high-resolution ultrasound, 3D, 4D ultrasounds, and 5B elastography. These are some of the examples. Here on the left-hand corner, you can see ultrasound scan of the breast. Nice tissue planes. It's a benign cystic lesion. And the next one was a transfrontal ultrasound scan of the brain. And this is 3D scan of a fetus. And this is a high-resolution ultrasound scan of the hand showing small joints with synovial thickening and increased vascularity that indicates synovitis. And if you have erosions, you can detect these erosions before they appear on the plain X-ray. So it's a very good modality in assessing inflammatory arthritis. And the next one was a high-resolution scan of the shoulder joint. You can see the tissue plane nicely, and this is a distended subacromial bursa. In computed tomography, with the development of high-powered X-ray tube and generators and simultaneous tube movements, and with the introduction of highly sensitive detectors and multi-detector OCTs, introduction of sequential scan modes and powerful post-processing tools, you are able to produce high-resolution images. We can cut down the time taken for scanning. It's an advantage for patient, it's comfortable for patient. We can acquire any volume of any part of the body and produce multi-pane reconstruction, and there are a lot of new applications. Here you can see scan from head to toe can be done within few minutes. Any volume can be acquired, and any way whatever the way you want, you can reconstruct. Any phase with the multi-phase scans, you can do arterial phase, venous phase, portal venous phase, pancreatic phase, or delayed venous phase within single contrast injection. And this is a high-resolution scan of the temporal bone, and this is a reconstruction of the same thing with the same quality without repeating the scan. And this is a CT angiography. This is the latest development in CT. With the multi-detector CT, you can do angiography of any area, whether it's central or peripheral arteries, with great accuracy. And you can produce that in 3D mode, or if you want, you can view in whatever the way you want, at different angles. This is a patient with the melena, and arterial phase of this scan shows an active bleed. This is an active bleed in the proximal jejunum. This post-processing image shows the feeding artery and the active bleeding. So whatever the intervention, you can guide from this image. The CT coronary angiography. This is the advantage of new advanced techniques. This is a non-invasive screening tool for coronary artery disease. You can incorporate calcium scoring into this, and with this current development of non-communicable disease in our country, this is a very useful screening tool. CT colonoscopy or CT colonogram. This can be incorporated into routine CT abdomen scan, provided patient should have good bowel preparation. And this is a good screening tool. You can see the images as you are seeing on colonogram. This is the imaging for small bowel, CT enterogram or CT enteroclysis. Here, the normal person can see distended bowel loops. You can see within the lumen as well as around the lumen. Here, patient with inflammatory bowel disease, you can see non-distended segment with wall thickening, and here enhancing mucosa that indicates active inflammatory bowel disease. This is a patient with Crohn's disease. In digital subtraction angiography or DSA, The advancement are more towards the interventional radiology, therefore I am not going to discuss this in detail, but for diagnostic purposes, we can have high quality images, high quality angiograms, and with single contrast injection, you can do 3D rotational angiography, thereby you can reduce the contrast dose to the patient and get whatever the angle you want in images. And if you want to do a limb angiogram, with the single contrast injection, you can outline entire arterial structure of the limb. In MRI, the advancement is more, and advancement is profoundly seen in MRI, I would say, with the development of high field magnetic units, improvement in gradient performance and coil technology, and powerful cross-processing unit, and advances in other scan hardwares, advances in pulse sequence design. We are able to image the whole body with new imaging techniques with better signal-noise ratio, the better spatial resolution, and we can get more information. Here you can see the brain is seen in different planes. We can acquire whole volume and reconstruct in whatever the way with very high resolution, very good pictures. We all like to see good pictures, but being radiologists, this is paramount important to us to secure our jobs and to give more information to you. And this is a high resolution scan of the brain stem. You can see the fine detail of the structures around the brain stem, cranial nerves leaving the brain stem, and small vascular structures, vascular loops, and small tumors in this area can be detected by these imaging techniques. And this is non-contrast, non-invasive MRCP, that is evaluation of the biliary tree. It's a dilated biliary tree with multiple calculi in the distal common bile duct. This is the MRA, non-contrast imaging modality. MRV without any contrast, you can see the image quality and diagnostic ability. These are two images from two different scanners of the same patient, 26-year-old female with MS, multiple sclerosis. This is with the 1.5 Tesla scan. You can see few demyelinating plaques in this periventricular region. These are so-called Dusen fingers. This is with 3 Tesla unit. You can see these lesions better, and there are some lesions detected in 3 Tesla which are almost hidden in the 1.5 Tesla. So when you increase the magnetic power, lesion detection is much more powerful. There are some new pulse sequence. I have selected 2 sequences here. This is a patient with multiple sclerosis again. This is our standard T2 and FLAIR sequence. You can identify these lesions, the demyelinating plaques, but in this sequence, the rightmost corner sequence, you can identify these lesions better. This is a double inversion recovery sequence. This is a patient with history of road traffic accident presenting with post-concussive syndrome. CT scan was normal. The FLAIR images is almost normal. These are non-specific white matter changes. Gradient echo sequence, this is normal, but this is a new sequence called susceptibility weighted imaging. These black color areas, these dots are microhemorrhages. Excuse me. This is a patient with diffuse axonal injury. Diffusion weighted imaging, Professor Heavitharan mentioned about that. I am sure you are familiar with this. This used to detect early ischemia. This depends on random water motion of the tissue. This is the first functional imaging technique we had. But now this is not confined to the brain. This goes everywhere in the body we can use this. This is a patient presented with sudden onset of paraparesis, standard T2 weighted sequence. If you look carefully, you can imagine the conus medullaris is thickened and there is subtle signal change. But this diffusion weighted sequence, you can see bright area there, which is blackish on the ADC map. That indicates this acute infarction in the conus medullaris. Diffusion weighted, we apply any part of the body, musculoskeletal or any other organs, GIT, and this is widely used in oncological assessment. This is a patient with bone metastasis of breast carcinoma. The standard T1 weighted sequence, you can identify some lesion. This is T2, you can identify more lesions on T2, but this is diffusion weighted sequence. You can identify numerous lesions in the skeleton. But this is the whole body 3D diffusion weighted image with little bit of post-processing. It's like a PET image. You can identify these lesions in the spine, iliac bones, upper femora, liver, axillary lymph nodes, hilar lymph nodes. So to assess the disease burden in the body, this is the best imaging modality. And this is widely used in post-therapy assessment. This is another patient with carcinoma of the breast. You can see the disease burden on this diffusion weighted sequence. This is 2 months after 2 months of chemotherapy. You can compare easily with this. You don't have to count each and every vertebral body, but you can assess this nicely. Signal intensity and number has reduced dramatically. This is a perfusion imaging. Professor Badam mentioned that it's a technique to measure cerebral blood flow and blood volume to the tissue. It's widely used in ischemia, cerebral ischemia, to differentiate the infarcted area from salvageable area, the so-called penumbra. But that can be used in other indications as well. This is one of the indications to differentiate tumor mimics. The top row of images, the patient with glioma. Here on clear sequence, you can see only the white color area, edematous area. You don't know where the tumor is. After giving contrast on this T1 weighted, still you can't identify exact tumor. But in perfusion image, you can see highly perfused area. This is the tumor, the red color area. This is after radiotherapy. The scan was repeated. Some changes in the temporal lobe on FREA. Post-contrast, there is some enhancement. You should be able to appreciate from the images, but we don't know whether it's a residual tumor or whether it's a recurrence or post-radiation changes. The answer is here. There is no increased vascularity, but there's decreased vascularity. That means that is post-radiation necrosis. MR spectroscopy is a non-invasive technique to study and analyze the metabolic changes in the brain. Commonly we use for brain and prostate. These are the common metabolites we used. There is a pattern of spectrum. This is a normal brain. Something is happening here. In the right top corner is a normal spectrum with NAA, that is a neuronal marker, is very high. That's a normal thing. And second and third peaks indicate choline and creatinine. They are the energy marker and cell turnover marker. In the top middle, I need some help. The top middle image shows increased choline levels and creatinine levels with reduction if NA. The mouse is not working. Two effects of technical advancements. Yeah, top middle one, I can't show from here. It's a low-grade glioma. And the top right-hand corner is a high-grade glioma where you can see high metabolic activity and reduction in neuronal markers NAA. On the bottom left-hand corner, the metabolic rate has gone up, cell turnover has gone up, neuronal level has gone down, but there's an additional peak that is called lipid lactate peak that indicates tumor necrosis or anaerobic activity. In the next one, lymphoma, almost same. And the third one indicates reduction in all metabolites. That's the case of post-radiation. And the most right-hand bottom corner, you see all the metabolites have gone down except lipid lactate that indicates anaerobic metabolism is going. That's the case of cerebral abscess. Diffusion tensor imaging or DTI, this is a technique to demonstrate white matter fiber tracks. This provides outstanding map of anatomical connections between different parts of the brain. It's very useful for neurosurgeon in planning his surgery. And this is a patient with mass lesion in the posterior temporoparietal region. First one was a FLAIR image, second one is contrast enhanced image, and third one was a DTI image, diffusion intensity image. It shows medial displacement of the optic radiation without interrupting the optic radiation fibers. That indicates the tumor is not infiltrating, it's just displacing. It's a valuable information for the surgeon. fMRI is an indirect measure of neuronal activity. It's a blood oxygen level dependent sequence. fMRI data can be obtained after activating different centers. It may be language, memory, visual, or motor functions. This is used in patients undergoing surgery, neurosurgery, or patients with dementias, phobia disorders, and some psychiatric illnesses. This is a patient with glioma in the perirolandic area. The second image of the right-hand side, it shows activation of the motor area, the finger tapping test. The motor fibers are immediately posterior to the tumor. This is a patient with arteriovenous malformation. The white color areas are the dilated vessels. The tongue motor area, the pink color area you can see is immediately lateral to the motor area, to the lesion. And the second and third images, middle and right-hand corner images, are from DTI, diffusion intensity images, to demonstrate corticospinal tracts which are lying immediately medial to the lesion. These are very valuable information for surgeon or interventional radiologist who is going to treat this. And prostate imaging, multi-parametric prostate imaging is a great achievement in this advancement. We use multiple pulse sequences to evaluate the prostate. The first one on the left-hand corner, T2 weighted sequence, you can see the black color area. The second one, dynamic contrast enhanced scan. And third one, the bottom one was the diffusion weighted sequence. And middle one, in the last row, is a MRS. On the right-hand corner, you can see the normal spectrum, which shows high citrate level and low choline in normal prostate. In the left-hand side, in the cancer area, low citrate and increased choline, that indicates it's a prostatic cancer. MR mammography is a very good image, very useful imaging tool in glandular breast where the conventional mammogram and ultrasound fails. And we have multiparametric breast imaging similar to prostate to evaluate breast lesion, and this patient with carcinoma of the breast showing diffusion restriction, increased perfusion, and dynamic image shows acquiring rapid perfusion and rapid washout of contrast. MR enterolysis or MR enterogram is a better imaging modality for evaluation of the small bowel. In contrast to CT enteroclysis or CT imaging, there is no ionizing radiation involved here, so it's a safe method. This is a patient with Peutz-Jeghers. You can see multiple black dots in the proximal jejunal area. Those are multiple polyps. Some images from MR enterolysis. On the left corner image, you can see the yellow arrow indicates two bowel loops showing loss of distensibility and mural thickening, and the middle one shows long segment with mural thickening and mural enhancement, and the left-hand corner enhancing mucosa, that's the inflammatory bowel disease and active disease. With this superb soft tissue contrast, we can demonstrate anatomy of the uterus, cervix, and ovaries clearly, and thereby we can differentiate, we can demonstrate the pathologies in this region, we can do the accurate staging of malignancies in this region. This is whole body screening for diffuse diseases or generalized involvement of the body, and it's a fast screening sequence. I have to go fast, my time is finishing now. Cardiac MRI is a major development in our field in recent. Fast, functional, structural, and ischemic disease of the heart can be assessed by this, and it's a very good imaging tool and shown promising results. PET scan, you all are familiar, both previous speakers showed. We know it's a very good use, very useful tool in oncoimaging. staging, assessment of treatment response, and recurrence. But it can be used in rest of the body as well, in differentiating different types of dementias or epilepsy which are not seen on structural imaging, or in degenerative brain diseases, this can be used. So to finish this talk, I have to say what I request from you: give us the clinical problem, your possible diagnosis or possible differential diagnosis. Then we can plan, we can select the suitable imaging modality, we can plan the protocol or whatever the false sequences. You should be able to give a diagnosis or narrow down your differential diagnosis. We have come a long way from the days of Ranjan, ladies and gentlemen, but yet we have a long way to go. Thank you very much for your attention.
Thank you, Dr. Munasinghe, for that very interesting lecture. It is time for the questions. We have a couple of more minutes before we go for the lunch. Dr. Paul over there. Can we have a mic over there?
Thank you for the excellent lectures. I'm one of the resident physicians. In our day-to-day practice, we come across a lot of patients where we need to do contrast CT scans, but the patient's renal functions are not very good. So is there any safe level of GFR for us to proceed with contrast studies? And is there something like reducing the dose of contrast to do such studies? That's my question.
In my presentation, I mentioned that it is 60 ml per minute. That is the sort of eGFR we are looking at for CT. And actually, you don't have to be, I mean, if the clinical indication is clear, if you are sure of the sort of clinical indication, you have to go ahead. I mean, so I mean, it is, even if you get, so you do 72 hours serum creatinine level or eGFR, and if there is a contrast-induced nephropathy, you have to dialyze the patient. So it's like that. So we don't have to be sort of scared of the investigation. You can go ahead and do it.
I will add to that, you can do NAC cover. You can start NAC 24 hours before the study and continue the day of the study, and you can follow up with next day.
Thank you for that answer about neck. But is it still controversial, because some people do?
Actually, I did not mention it is controversial.
Yeah, is there sort of like a consensus as to, because some people do practice well hydration, or some people do practice giving bicarbonate, but is there sort of like a current standing?
In our setup, of course, we are blessed with a nephrologist, so we always confront the problem to the nephrologist, or we discuss the problem at the MDT. So we come out with the sort of best thing for the patient. I think NAC is controversial, I do believe. And pre-procedure hydration, that is the most important thing more than NAC. So we need to hydrate pre and post procedure.
Singer, do we have all these high gadgetry in Sri Lanka, the fMRIs and all that?
Yes, especially Professor Rajapaksa instructed me to use only the techniques available in Sri Lanka. So I have carefully selected all the modalities and the sequences available to us in Sri Lanka. All these things what I have spoken are available in Sri Lanka. Those images are from my hospital.
Thank you for those excellent presentations. I want to know, when we do X-ray lumbosacral spines for backache of those patients who have some symptoms, when we see straight lumbosacral spine, what's the significance of that? and do we have to do anything more about it? Similarly, straight cervical spine.
So it could be just spasm, which is a temporary thing, but depending on the clinical findings, if there are neurological signs, we may have to proceed for MRI. That depends on the clinical findings, other clinical findings. Just merely a straight spine it will not warrant further investigation.
Thank you.
Another question, this is to Professor Vitarna. You mentioned that skull X-ray is obsolete in terms of investigation of headache. We do still practice, I suppose, in the periphery as well. If you are clinically thinking about sinusitis, what's the situation with that? And number two, about abdominal X-rays, because when I was in foreign training, I tried doing the abdominal X-ray at first, then people might as well go directly to a CT abdomen. In a low resource setting, what is the standing with regards to those two investigations, simple investigations?
So you have two questions basically for headache. I think sinusitis, sinus X-ray is obsolete, because for simple sinusitis, treat it. Why do you want, what is the additional information you are going to get? You are not, you will see opaque sinuses, so what is it? Unless you get, the only thing is you can do an erect sinus wave and look for a fluid level. If you are in a low resource setting, so request your radiographer to do an erect sinus wave, which will show you a fluid level. That means there's a secondary infection. But most of the time, that is plain and simple sinusitis, that you don't have to do X-ray. If you have a recurrent sinusitis, and if there is a severe epistaxis, or there's a bleeding tendency, if you think there's a malignancy, straight away go for CT. Please don't waste time on X-rays. And the other question, I was not very clear, abdominal X-ray in a child or adult?
In an adult with regards to acute abdomen, you mentioned about doing the abdominal X-rays, but in the West, they're straight away going to the CT abdomen.
Yeah, that depends on the clinical scenario actually. If it is a real emergency, you may go for it, go for CT, and also the availability in the institution. So if you don't have a CT, you have to do X-ray. But the trend is actually going away from the X-ray. So in our institution, we usually, for X-ray, if it is a renal colic, so we do ultrasound and patient will go for CT KUB. So you avoid doing a CT, plain X-ray KUB, because what is it doing? Just sitting in between. So you can't get any management decision on that. Perforation and intestinal obstruction. So those are the two main acute abdomens. So, intestinal obstruction, if you do a CT, you will get the cause and the site of obstruction. So in the plain X-ray, yes, if you are, sitting on it, and if you want to buy some time, yes, you can do it. But, if you have the accessibility to CT, might as well go for it. But in a periphery, definitely, you can't transfer the patient immediately without doing X-ray, so you need to do. But you can do ultrasound scan. Ultrasound will tell you whether it is paralytic ileus or intestinal obstruction by looking at the peristalsis. So ultrasound, and perhaps you may skip the X-ray and go for CT straight away. That depends on the clinical scenario. If you are thinking of adhesions or something in a patient with multiple surgeries in the past, so X-ray is not going to help much, but CT will show you the adhesions, the site of obstruction. There is a way of diagnosing adhesions in the abdomen in CT. So if there is a mass or something, you will detect it. So the cause of the obstruction is the main thing if you are looking at. I hope I answered your question.
Thank you very much, ladies and gentlemen. That's the end of the questions and answers and the symposium. And could I have Dr. Vasant Disanayak, the immediate past president, to deliver the certificates of appreciation. Professor Badra Hewavitarana. Dr. Vikrama Salgado. Dr. Sanjeev Munasinghe. And I'll keep this. Ladies and gentlemen, that's the time to retire for the lunch.